Hi, we're live. Welcome from the Paley Institute in South Florida. Thank you for joining us in this hectic time. I'm Dr. Craig Robbins. I'm an orthopedic surgeon, and I'm going to give a talk today, straight talk about crooked legs. So what are they? Most of us have an inherent idea of what a straight leg looks like. Therefore, most of us have an inherent idea of what a crooked leg looks like. So I'm using the colloquial term crooked to be anything that doesn't look straight. And we'll talk about different causes and treatments, and we'll talk about this for adults and children, and have a general discussion about this topic. So some examples here. This child on the left is a 16-year-old young woman who has a crooked leg bowing on the right side. If you're very astute, you may notice some scars on her left leg where she's had previous surgery, but she had a condition called Blount's disease, and we'll talk a little bit about that later. This is a child who has what's called This is a child who has a condition called knock knees or valgus. This is a child who has bowing of the legs, which is an example seen here. So these are examples of children of various ages with something called crooked legs. In general, I think crooked leg can come from the feet. It can come from a problem with rotation, or it can come with a problem with angulation, such as the knock knee and bow leg. And today what we're going to concentrate really are on the angular problems. In future talks, we'll discuss problems with the feet, and we'll discuss problems with rotation. Examples of problems with the feet are the child on the top with clubfoot, and here's an adolescent with a flat foot. Examples of rotation problems are this toddler who has something called tibial torsion, where you see the leg has rotation and this foot is pointing inward. And then an example of this child who has something called retroversion, where his hips allow them to rotate outward much more than they can rotate inward. But we're going to really focus our talk today on angular problems such as knock knee and bow legs. So where do they come from? So as with most things we get from our parents, we get the shape of their legs. If both of our parents are very knock-kneed or both of our parents are very bowed, we have a higher chance of having that. So there's definitely a hereditary component. There's also a component that develops while the infant is inside of the mother, and that's something we call intrauterine packaging, and I'll explain that again in a few minutes. And then there's another cause of this is trauma. If you're a young child and you have a broken bone and that break affects the growth plate, that can affect the way that future bone grows, and that can create an angular problem. So sometimes it affects both of the legs, such as a congenital problem that you inherit bowed legs from your parents, or it can be one-sided only, such as if you break your knee riding your bike and it affects the growth. This is an example of a child who has a metabolic cause, meaning it's something to do with either their diet, lack of taking in the right nutrition, or it's something they inherited from a parent where their body can't process. So there's many causes of rickets, and in this case, this child did not get enough vitamin D in their diet, and they had a pretty classic appearance of some knock knees and a little bit of widening at the growth areas near the knees and the wrist. This child was treated with medication and actually got better. So X-ray appearance of what rickets looks like. This is an example of a young girl who broke her ankle when she was about 5 or 6 years old. We're looking at the normal ankle on the left side, the abnormal ankle on the right side, and you can barely see her growth plate in here. She's still growing, but her ankle is 90 degrees to the long axis of her bone. That's normal. But on this side, the way she broke her bone, it affected the growth, and it made her ankle grow into this outward bowing. So just like you can get bowing at the knees, you can also get bowing down at the hips and at the ankles as well. So in the sideways view, you see she's standing a little bit to the side of her foot. So this is an example of trauma causing bowing in the leg. There are lots of other reasons, and this is a child who has a genetic condition where her ligaments are very loose. It's called Ehlers-Danlos, but we have a post-traumatic, we have from infection, we have from tumor, a whole type of disease process called neuromuscular, such as cerebral palsy, and many reasons that can cause angular problems. The good news is that if this is something you're born with and it's affecting both sides, and there wasn't infection, and there wasn't tumor, and there wasn't trauma, most of these things are self-limiting and they will correct over time. Mother Nature takes her course, and children go through their normal physiologic development, and they start sitting in the W position, or they start with a little bit of bowing, or they start with a little bit of flat feet, and just nature takes its course and these things correct themselves. So this is an example of a child who had bowed legs. They were a normal child. They didn't have problems with their diet. The parents both had straight legs, and we made the decision to watch this child over time, and over the course of 2 years, their legs straightened up on its own. So this is a child who had normal physiologic bowing, which we expect in certain age groups. On the far left side of the screen, I have an x-ray of a person standing straight, and I'm going to start talking to you a little bit about the radiology of limb alignment. So if I'm looking up here at the hip, and I'm looking down here at the ankle, and I'm looking at here at a knee, a normal leg or a straight leg is one that's basically in a straight line. The thigh bone is called the femur. The shin bone is called the tibia. So we can call the line between the hip and the knee the femur line. We can call the line between the ankle and the knee the tibia line. So we can call this the femorotibial angle. And in general, a straight leg is one where the hip is over the knee is over the ankle, and a line drawn between the hip and the ankle goes through the knee. That's a straight leg. So now we're starting to take these problems and quantify them. So not going to be much math, but there is one graph and telling you what this means in quick terms. As you're young, birth 1 year, 2 years, this femorotibial angle is more towards being bowed. But once you hit about age 2, 3 years old, the normal development is such that the knees will become straight. They'll even become a little bit knock-kneed. And usually by age 7, the alignment of your legs is fixed and is straight, and the way you are is the way you're going to be. So this is just a little picture showing that. The same child at age 2 with a little bit of physiologic bowing, the same child around age 7 with a little bit of knock-knee, and then once you reach skeletal maturity, nice straight legs. And that's the general course for most people. If we want to get rid of those, if we want to close up and look at the knee more directly, this is a picture taken from an orthopedic journal article that I've referenced here. We're looking at a very close-in view of the knee, and you can imagine this x-ray I had on the side. The hip is up here, the ankle is down here, and I'm drawing a straight line between the hip and the ankle, and I'm looking to see where that line crosses in the knee. So in someone who has a perfectly straight leg, that line passes right towards the middle part of the knee. This is what we call a straight leg. If the leg is shaped a little bit like this, and we draw that line, we can see that that line is coming on one side of the knee or the other side of the knee. And we can talk about where that weight-bearing line passes through the knee, and we divide the knee into quadrants. In a very general sense, if that weight-bearing line passes in the inner half of the knee, you're not going to have any problems. If that weight-bearing line is passing too much to the inside, which means you're bow-legged, or it's too much to the outside, which means you're knock-kneed, that's when we worry about future problems such as arthritis. Arthritis is a very complex thing, and there's many factors that affect it in addition to the shape of your legs. So Blount's disease is a very classic problem that kids have that causes bowing of the legs. I don't actually like the term disease, I like the term condition, so I call it Blount's condition. But Blount's comes in many forms, and it affects kids of different ages. An example of Blount's is in a young person we call infantile, and an older person around 7, 8, 9 we call juvenile, and then in an older person before the skeletal maturity in their early teens we call adolescent. They're all forms of the same process that cause bowing of the legs. So the treatment will depend on the age and how severe things are. In the old days I mean since before I started training, we used to treat a lot of these angular problems with braces. And if you look around, not many kids are running around with braces these days because they were proven ineffective and they're not comfortable to wear and they just don't work. So most of the treatment is either observing, knowing the natural history and expecting that things will correct on their own, or a surgical intervention. So bracing is an option. It does work in the very young children. Guided growth, something called hemiepiphysiodesis, which I'll talk about, is a surgical procedure where we take advantage of the fact that a child, 7, 8, 9, 10 years old, even into the early teens, is still growing. So we basically put an internal brace on the growth plate, and this allows the leg to correct itself with growth. If the child is either too old or doesn't have enough growth left, for instance, a 14-year-old who has a very crooked leg, we can't do the guided growth method. We do something called internal fixation or external fixation, which are more complex procedures where we actually cut the bone to make it straight. So, for example, this is a young child who had a very mild case of infantile Blounts. If we looked at her hips up here and we looked at her ankles here and we draw that line, we see that the line goes to the inside of the knee, so we can start to quantify this and say this child has a bowed leg. So the surgeon in this case opted to not do surgery and to try leg bracing, and the child wore the braces intermittently. They were difficult to put on, they were difficult to wear, and after about a year, the patient and the family decided this is not the way they wanted to go, and this child actually underwent a surgery. It's a small incision and the bone was actually cut and the bone was rotated. This is an example of surgery that was done prior to the commonplace use of this guided growth that I'm about to speak about. So another example of a child with infantile Blounts. This child did not have a metabolic problem. This child had a problem with the bones and the growth. And looking at the x-rays, if we draw our weight-bearing line, we see that line goes very much to the inside of the knee. And looking at the growth plates, we see that this child has normal growth plates, so it's not a metabolic cause. This child underwent the procedure that we call guided growth, or we call hemi, meaning half, epiphysiodesis, meaning growth plate affecting half of the growth plate. And basically, it's taking that external leg brace and shrinking it down and putting it inside so we are telling the growth plate on the outside only not to grow as much as the growth plate on the inside. There's an orthopedic principle that I won't go into the details, but it basically says if we can tether the growth on one part of the growth plate, for example, with a small plate and screws, then the other part of the growth plate will respond and will grow accordingly. So this is also called, if you look online and you look in the literature, this is also called an 8 plate because it looks like the number 8. So if we're looking at the x-rays before any of these devices were placed inside the child, we see there's a certain amount of bowing. And if we looked at the child about a year later, we see that the legs are much straighter, and we see that these devices are on the outside part of the growth plate. These devices were placed through a surgery that takes about 45 minutes. It's about a 1.5 centimeter incision. There's very quick recovery. The child does not need to be in a cast. As soon as the incisions heal, they can resume sports and swimming and things like that. The important thing to note is that the day these were placed, the screws were placed relatively parallel, and as growth occurs, the screws start to diverge, and that's causing the growth plate to straighten out. So we'll follow this child every few months with x-rays. We'll look how they appear clinically, and we'll draw this line on the x-rays. And when that leg is straight, we will then remove these internal braces. We will remove these 8 plates and allow growth to resume its normal course. Now, in a very young child or in some children with different conditions, there's always the possibility that even though we get the leg straight with these devices, it may actually recur into that bowed legs, and they may need a second course of this type of treatment during their childhood before the end of growth. So what if a child comes and they're 15 years old and they're 16 years old and they're not growing anymore? So this is an example of a child who does not have active growth plates. If they don't have active growth plates, then we can't guide growth, so our options are to leave the leg as it is or to perform a more involved surgery where we cut the bone. That's called an osteotomy. So in this case, I attached a device to the child's leg, an incision is made on the bone, and this device has a series of actuators. The child goes to sleep with a crooked leg and they wake up with a crooked leg, but they have this device attached to them. And over the course of 2 or 3 months, making very small daily adjustments to these actuators, the child and their family will very slowly pull the bone into the correct position by making adjustments to this. They're full weight bearing after this. The incisions to place this are very small. They can walk, they can go to school, they can swim after the incisions are healed. And this is a way of slowly correcting the curvature. And when you're done, you notice that the rings have moved into a more parallel position, and you can see that the overall alignment of the leg is much improved. So, very crooked leg before, you can see the leg is back to straight, and these small scars are the extent of the surgical incisions. Most of the scars represent where small pins were placed in the bone, and the 2 small scars here are where we actually cut the bone to allow it to be made straight. So this type of treatment, where they wake up with a device on their leg, allows for gradual correction. And the reason we choose to do this is 1, we can't guide the growth because they're not growing anymore. 2, it allows us to correct multiple problems at once. So without getting into too much detail, this child had rotation of the leg as well as angulation of the leg. So with this device, we can correct multiple problems at once. Oftentimes, and it's not represented here, oftentimes when the leg is this crooked, if we could see the whole pelvis, we would see that the other leg is actually longer because the bowing of the femur and the tibia makes the leg shorter. So when we make the leg straight, it adds length. But sometimes the growth is affected so that even when the leg is made straight, it's still short. So with treatment such as this, we can allow correction of the angulation and we can add length. So at the end of the treatment, both legs are the same length. So here's the final x-ray. You see very crooked here, and you see very straight here. This is another example of a child. It affected him on both sides. His growth plates were still moderately open, meaning we could have tried the smaller surgery with the guided growth. However, I didn't believe he had enough time left. So he underwent treatment of both sides. We did surgery on one side first, started the correction, and then a few weeks later replaced the other device. And this child was going to school and walking and participating in activities. The whole duration of treatment to get his legs straight from the day they were put on until they were removed was about 5 months. Back to guided growth, showing you more examples. Guided growth we call hemi, meaning half. Epiphysiodesis is guiding the growth. So here's an example of a child before surgery who is about 14 years old. He had a knock-knee deformity. His growth plates were still open despite his age of 14. Some 14-year-olds are still growing, some are not. So we will sometimes use additional x-rays to look at the age of the patient, how their skeleton is behaving. And an interesting thing to consider is we draw this line, it's clear that this child's legs are valgus or knock-kneed, and it's interesting to look how far apart his ankles are. This is a relatively tall child, and his knees rubbed together. He was very athletic, and it bothered him when he played sports. If he continues to grow and the angle of the femur and tibia stay the same, if he continues to grow, his feet will be here, and his feet will be here. So even though the angle of the leg stays the same, his feet get further apart the taller he grows. So in some of our patients, even though the amount of actual angular deformity is very mild, 3 or 4 degrees, if they're very thin or very tall or very active, and their feet are far apart, then sometimes that's an indication to intervene surgically as well. So this child had the procedure where we did small incisions. We placed these internal braces or 8 plates or guided growth plates, and over a course of several months, the legs straightened out. We follow them routinely with x-rays every 3 or 4 months, and one of 2 things happens. They reach the desired amount of correction, and we remove the hardware, or they happen to stop growing, and then these plates can remain for life, or they can be removed at any time if they become bothersome. Generally, they're not bothersome, and they can stay for life. Here's an example of a child who had a metabolic problem who was affecting all of the bones, but one leg was much more affected than the other. This is an example of an older technique that was used, not using the 8 plate, but a similar type of technique where staples were placed. And this can get to straight correction as well. I put this case on to show you that even though we have these newer techniques, the old techniques existed for a long time, and sometimes those are used as well. But the point remains the same, that we are taking advantage of the fact that this child has open growth plates, and we were guiding growth. One of my final examples I'm going to show you, this is a gentleman who came to me in his 40s. He had bowed legs for his whole life. He never had any sort of treatment or surgical intervention. He was very active but had a lot of knee pain, and it's pretty clear that his legs were very bowed. So we can measure these angles, we can quantify how bowed the legs are, we can come up with our treatment program. It's obvious that we're past the point of guiding growth because he's no longer a child, and his options were to proceed as he was, or to do surgical intervention where we cut the bones and straighten them. Now at some point in time, his knees will probably wear out enough to the point where he may even benefit from a knee replacement. The problem is, when your leg is crooked, it's very hard to do a knee replacement because you have to, the bones are so crooked, it's difficult to get them fully straight. Plus, it's possible that if we get his leg straighter, all that abnormal stress will come off of his knees, and possibly his knee pain will improve. And without getting ahead of myself, his knee pain did improve, and he didn't get knee replacements. So it's a little washed out, you can't see very well, but I think you can see his ankles are down here, his knees are here, his hips are here, and it was a pretty complicated treatment program. You see metal rods in the thigh bones. We had to do bone cuts in the thigh bones as well. But this gentleman also had those external fixators you saw in the last case. We did one leg then the other, and over the course of I think about a year and a half, we got his legs fully straight. Incidentally, he lost weight and his knees stopped hurting as well. So the treatment algorithms are the same whether you're an adolescent who has stopped growing or you're an adult. We can treat crooked bones with the same techniques. So in conclusion, there's many causes of crooked legs. In the beginning of this talk, I showed you some examples of feet and rotational problems such as in-toeing or out-toeing, and these are topics for future Facebook Live sessions we'll do from the Paleo Institute. What we spent a lot of time talking about today were crooked legs with angular problems such as bowed leg or knock knees, and most of these, if you're a normal developing child and you have no metabolic problems or genetic problems, will self-correct, but observation is a good thing, whether it's through the pediatrician or through your pediatric orthopedic surgeon. But the ones that cause functional problems, or the ones that cause pain, or the ones that we predict will cause problems in the future may need more intervention, and that's where surgery can play a good role. The goal of all of these treatments is to realign the legs to within that straight knee x-ray I showed you in the beginning to prevent future problems. So in the future we'll do some additional talks. We'll actually spend much more time talking about rotational problems such as in-toeing and out-toeing. There's a condition called miserable malalignment you may have heard of, and we'll delve into some other things as well. So we had a few questions come in. And one of the questions that came in, I've talked a little bit about, is about what's the role of angular problems or crooked legs in the development of arthritis. And I said earlier, arthritis is a pretty complex thing, and there's many factors that affect it. The level of activity, the weight of the patient, what their occupation is, what their sports are that they play, or their recreational activities, and how crooked the leg is as well. In general, we find that patients who have more of a bowed leg are more predisposed to developing arthritis than patients who have a knock knee, but both can actually develop to knock knee, and there is some correlation with how crooked your leg is and how much arthritis you may get. But before surgery, there's lots of things that can be done for knee arthritis. First and foremost is getting on a good diet, healthy exercise, weight loss, strengthening your muscles, and things like that. So just because you have a crooked leg and knee pain doesn't mean you necessarily have arthritis or you need a knee replacement, but it's at least something you should get checked out. What other questions did we have?
My 12-year-old boy has knock knees. Should I be concerned, or should I wait for them to straighten naturally?
Great question. So if we remember that graph I showed you earlier in the talk, once you reach about age 7 or 8, the shape of your legs is the shape they're going to be until you finish growing. So at age 12, I'd recommend getting seen sooner rather than later, especially if your child is precocious or going into puberty early. They may only have 2 or 3 more years of growth, and if there is any need for surgery, you may run out of time to do the simpler surgery with the guided growth. So an adolescent or a pre-adolescent who has legs that are bowed or not is worth getting seen with x-rays and pediatric orthopedic surgeon evaluation. Next question.
What are examples of functional problems caused by knock knees or bow legs?
Great question. So a functional problem would be an example of the child I showed earlier who was the baseball player who had knock knees, and I drew the picture showing the legs were longer. So if my knees are like this when I'm walking, and every time I run, and every time I play baseball, and every time I slide or I ride my bike and I'm hitting my knees, it's bothersome to the point where I don't want to participate in that activity, then to me that's a functional problem. Whether it's sports, whether it's sitting, whether you don't like that you have to move your knees around each other to walk because they're so not. So that's a functional problem. It interferes with your normal functions such as walking or sports. Similarly with bow legs, if you find that I like to play basketball, but after an hour of basketball my knees are hurting, and I think it's because the shape of my leg, it's not because I fell down and hurt it or did some other trauma to it. If there is a shape of your leg is so misshapen that you think it's affecting your function, then that's what I call a functional problem. You don't just have to have pain for there to be a problem. Do we have more questions?
We have one more question.
Okay.
Is there any future in stem cells or biologics in treating knock knees or bow legs?
That's a great question. So at the Paley Institute, we like to think that we're on the forefront of all things that are forthcoming in the treatment of children and adults with all types of angular problems, congenital problems, defects from trauma in adults and kids. And we do a lot of the surgical reconstruction. In our institute, we're not doing things like stem cells, but from my reading and what I'm seeing, there may ultimately be treatments with stem cells or some sort of non-surgical intervention, but it doesn't change the fact that if the bone is in a crooked shape, something needs to be done to get the bone back to a straight position. Now, if that day comes where there's targeted gene therapy or some sort of injection and it does that, that's great, but I don't see that at any time in the near future. And if there's no more questions, with that, we'll end it. Thank you, and I hope you have a safe day. My email, if you want to email me directly, there should be links through Facebook, but my email is my name, Robbins, Robbins, @paleyinstitute.org. Thank you for spending time with me.